G'day, I'm Jedynak, international educator and podiatrist, helping health practitioners master new treatment skills so you can get better clinical outcomes. Yesterday, I received a great question about ankles, metatarsals, and hallux valgus. Oh, sounding pretty juicy, huh? In fact, there were 3 great questions. They came from Aaron WICKS, who graduated from his foot mobilisation training last year. Aaron is a podiatrist who hails from Townsville in Queensland, Australia. He's a really proactive practitioner and a great inspiration to me. So Aaron posted on the FMT Society of Soul Savers on Facebook. It's a place where graduates of our foot mobilisation workshops can ask questions, seek advice and chat with each other about some cases. These are the questions Aaron posed. Hello fellow FMTers, just wondering when you're dealing with HAV, how much of the intermetatarsal angle and hallux valgus angle is considered too severe to correct with FMT? With the tool-assisted massage, what tissues are we targeting for HAV correction? And with chronic ankle pain, ankle instability, do people usually refer for MRI to check for osteochondral lesions, meniscal bodies, ankle synovitis before undertaking the protocol? Would an osteochondral lesion be a contraindication? Thanks for your questions, Aaron. Great to have sought clarification so you can deliver the highest quality service to your patients. To help you, the viewer, be very clear on each of Aaron's questions, I've shot 3 separate videos answering each question individually. I thought that if Aaron has these questions, then it's highly likely that other practitioners are also wondering the same thing. This video will answer question number 1, and then there'll be separate posts for the 2nd and 3rd questions. So let's rock into it. Question number 1, how much intermetatarsal and HAV angle is too great to correct? Just so that you, the viewer, is in the loop of what Aaron's referring to, the intermetatarsal angle is the angle between the 1st and 2nd metatarsals, which you can see here with this image. The HAV angle is the angle between the 1st metatarsal and the proximal phalanx, which you can see here in this image. Now, Aaron's asking if there's a point where the angle is so great that conservative treatment with manual therapies is not worth doing. Okay, Aaron. The angle is never too great to treat with FMT. In other words, FMT can be highly effective no matter what the HAV angle is. I'll show you a case study a little later to prove the point. Even with extreme joint displacement and chronic connective tissue adaptations, all you have to do is achieve as little as 10% increase in joint mobility. And this alone will make a measurable difference to the synovial fluid production in the joint. This means just by getting a little more movement in the affected joints by utilising foot mobilisation, nature's lubricant, synovial fluid, will increase. And this can make a world of difference to someone who has dried up, stuck joints, even if their joints are extremely displaced. Now, another question you might also be thinking is, how much correction can be achieved with extreme joint displacement? This varies wildly depending on the individual's history and clinical presentation, but have a look at this example here that I'm showing, and this is pretty extreme. You can see a very high AD duction of the 1st metatarsal and very high AB duction of the hallux. And now you can see the post-treatment corrections achieved through manual therapies. This is an example of how much correction can be achieved through FMT and manual therapies, but not every case will respond to this degree. So when you've a case of high joint displacement, Ted's tip is this: communicate openly to your patient in this way. These are the exact words that I use. Mary, in theory, you should be able to achieve some correction. The truth is, I can't predict how much change will happen, so I suggest we work together for 6 weeks and then reassess how we're doing. I'd even tell them that they should consider this treatment as a trial, which in fact is the truth. Remember, you're probably dealing with a patient that's had the problem for decades, so 6 weeks is a relatively short space of time. It's enough time to work with Mother Nature to stimulate cellular changes in the collagenous tissues around the joint. And really, what other options do they have? Surgery? Look, as a non-surgical option, you can't beat FMT and tool-assisted massage. I hope that's helped your thinking and decision making, Aaron. The next clip will answer which tissues you're going to target with your tool-assisted massage. Until then, serve with spirit, consult with care, and help more halluxes today. Today, in this quick 3-minute video, I'm going to answer Aaron's question, the second question, which he posted in the FMT Society of Soul Savers on Facebook. His second question was, with the tool-assisted massage, what tissues are we targeting for HAV correction? Aaron, the answer to this question is pretty straightforward, but before I launch into it, I want to do a quick show and tell. Just in case you missed the boat on the tool-assisted massage workshop I delivered last year, this is what we're referring to. These are stainless steel tools that are used to detect and correct fascial restrictions that form when periarticular structures like capsules, ligaments, muscles compensate for abnormal joint function. This usually happens over periods of time of months or even years. These tools can get into the small, tough connective tissues and release the knots. This dramatically improves the joint function without wearing out the practitioner's thumbs, fingers and hands. This is such a cool tool, and as the participants in last year's workshop found out, I absolutely would not work without this tool. So those of you who already know about this tool, you'll know that it's highly effective to incorporate it into your HAV treatment protocols. Now, to answer Aaron's question, when it comes to treating HAV cases, you need to target and release all of the connective tissues that have contracted. Now, which tissues are they specifically, I hear you asking? This can vary from person to person, so you need to assess for soft tissue restrictions individually. To help you out, I'll highlight the typical tissues that need to be targeted in probably 80% of the HAV cases that we see. First, you've got to check the deltoid ligaments of the talus. This is because the typical displacement of the talus in an anterior direction will stress these tissues. Next, head down to the first MP joint and the lateral ligaments and capsules of the joint when you get displacement of the hallux. It's in here that these tissues tend to contract and tighten up, holding the hallux in that abducted position. So you need to release these tissues. Next, check the intermetatarsal tissues of the first and second met heads. Continual tension from the adduction of the first metatarsal often creates tender points in here, so you need to get stuck into them. Now remember the sesamoid apparatus? We covered this thoroughly in the workshop. The tough collagenous tissues, particularly on the lateral aspect, they need to be released because the first MP joint function won't be restored if you don't release those. The other area you need to check carefully is the base of the first metatarsal, particularly if there's a high IM angle. The tissues at the base of the metatarsal here will adapt to their shortest functional length. And if you're going to have any chance of reducing the IM angle conservatively, you've got to release these. So, in summary, Aaron, the tissues you need to check and most likely need to release using tool-assisted massage techniques are 1. The deltoid ligaments of the ankle. 2. The lateral MP joint tissues. 3. The intermetatarsal tissues between the first and second metatarsals. 4. The lateral sesamoid apparatus attachment tissues. And 5, the base of the first metatarsal. I hope that served your thinking and decision making, Aaron. The next clip will answer what diagnostic imaging is recommended for... Can you believe it? I hope that served your thinking and decision making, Aaron. The next clip will answer what diagnostic imaging is recommended for chronic ankle conditions. You won't want to miss it. Until then, serve with spirit, consult with care, and help more halluxes today. Or should that be halluci? Today, in this quick 2-minute video, I'm going to answer Aaron's third question, which is, with chronic ankle pain and ankle instability, do people usually refer for MRI to check for osteochondral lesions, meniscal bodies, ankle synovitis before undertaking the FMT protocol? And then would an osteochondral lesion be a contraindication? To ensure I was giving you the best advice, I reached out to Adelaide's leading MSK radiologist, Sean Fowler of Fowler Simmons Radiology. I wanted to check if these lesions would be identifiable on plain film X-ray image. Sean came back to me with this. That's how he sounds.
Those conditions are not necessarily visible on X-ray, but they can be seen in some, but most of the time they're not visible.
But Sean's also taller than me, so I like this. Anyway, he also said, if seen, I'd recommend on, but not recommend anything in the report, as it depends too much on clinical setting and whether it requires further investigation. MRI may be needed in some cases like. So, the thing to be absolutely crystal clear on is, what are the clinical presentations that would justify ordering further investigation, such as MRI? Well, first, consider your patient's history and whether there's been any history of single traumatic injury to the ankle or repeated traumas to the ankle. Symptomatically, is there prolonged pain and swelling, particularly after periods of rest? And is there catching or instability of the ankle? You see, an osteochondral lesion is like blistering of the cartilaginous layers, and this can dramatically affect the normal articular functioning of the joint. If that's the case, FMT, releasing connective tissue restrictions, is not going to help these joint surfaces. Now, Aaron asked, would osteochondral lesion be a contraindication for FMT? In short, yes. In other words, I'd not use foot mobilisation in this case. Non-surgical treatment for osteochondral lesions usually involves rest and non-weight bearing to allow healing of the osteochondral tissues involved. Then physical therapy is implemented to gradually restore function. So if the clinical signs of abnormal, prolonged swelling, catching or significant ankle instability are present, then investigating further using MR imaging would certainly be indicated. If an osteochondral lesion is confirmed, FMT is contraindicated. Hey, I hope that served you, Aaron. Thank you again for sharing your questions. I know your colleagues are going to benefit from them. And thanks, Sean, my man. Sorry for taking the piss. I hope you still love me. Hey, if you found Aaron's questions and these answers helpful or useful, please share them with a colleague who'd also benefit. If you have a question on MSK conditions of the lower limb, please post them up here or send them to me via email at ted@footmobilisation.com. It's always great to hear from you. Until then, serve with spirit, consult with care, and help more people today.